Assalamu alaikum. It's wonderful to be here. Thanks, Dr. Mandesh and his team, for inviting me. I'm going to be talking about retrograde CTO PCIs in Pakistan. I practice both in US and here, and I have the pleasure of doing these things at both places, so I have to adjust myself when I come to Pakistan to the situations over here. So I'll be mainly concentrating on how I practice here, the retrograde CTO. I have nothing to disclose. If you look at the CTO incidence, it's anything between 15 to 20% depending on what data you see. But if somebody is any mild even CAD, there's a chance that they will have every fifth angiography will have one CTO. That's not a surprising finding. The most surprising finding is what happens to this thing is not moving very well, by the way. This is supposed to stick on the 9%, but anyway, we'll get used to it. 9% get, so here's a person who has symptoms, who underwent angiography, and there's only 9% of these folks went into PCI. Well, what's the reason? Firstly, these are complex lesions, and if you look at the Greg Stone, who is really the guru in CAD, because of the complexity, number one, they are under revascularized. So incomplete revascularization is one of the things. The other thing is that these folks are straightforward referred for cabbage. So according to Greg Stone, and that still holds true, is that this is the final frontier. Well, what is the difference when I practice here versus when I do it in Michigan? I'm emphasizing, I'm talking about my practice of retrograde here in Pakistan. The first thing is gadgetry. You don't get all the things all the time. You have to get things through alternative paths, and for this you got to have multiple sources so that you don't get stuck in the middle of your established practice. How about complications? Well, complications are strange entity here because number one thing is that you got to have the skills to deal with it, but beyond that, dealing with the family, and there comes the indication. So if you somebody brings his father who walked in your office, who was doing great, except the son wanted everything to be fixed, and you ended up in a complication, guess what? The family is not going to take that complication very well. You know Pakistani culture. Next comes we have prepayment cash system. So when we tell the person that, hey, you deposit 1 million and everything will be done well, when chips fall, you're on your own. So you may be giving your own fee there. All right. This is something we have to cut cost in Pakistan for the retrograde PCIs because it does involve a lot of gadgetry. And I have come up with this unique procedure. It's called retrograde. It's called proximal cap retrograde rendezvous. So this cuts down about 3 lakhs, 3.5 lakhs, but it is time consuming. Lastly, if you want to cut down on the cost and you're using sterilized stuff, well, that's a recipe for disaster. Also, if you have this see-one-do-one approach where you have seen some videos and you have gone for this 2-day courses, don't do it. I sent one of my own consultants, he went to Osaka and spent a week or 10 days and came back, and next month he had a mortality, and he never did retrograde PCI afterwards. So you need proper training. It's not see-one-do-one thing. You go there, you get trained for at least few months, if not a year, and then you will be good at it. So these two are the recipe for disaster. This is some of the data published by our group in Michigan. Our success rate was close to 60% with this hybrid algorithm with more complex coronary intervention. The success rate is around 86%, but it's all volume dependent. Since I just recently looked at the data, since I am their senior research associate. The key thing in success is your volume. If you're doing about 98 PCIs a year with a 50-50 retro NT, you're in good shape. But if you're doing anything below that, it becomes an issue. So how many of you will do this total CTO of the left main antegrade? The answer is, I hope no one, because if you try, this patient's not going to make out. The only way to deal with this left is a retrograde approach. So it does need added skills. I'm not going to go through this busy thing, but I want to show you you have to have proper indication for doing these things. Because when complications happen, this is a patient of mine I did just after COVID, and I had entrapment of the microcatheter and the wire. This person almost ended in coronary artery bypass grafting. So you got to be very cognizant about the fact that complications do happen. This is another patient with a perforation. Now, this perforation is not the perforation we are used to in a major artery, because you can cover stent and thing. No, the yellow marker, this pointer is not working. This is septal intramural perf that doesn't need much. But if you go to the left, just there's this dark spot. These are micro perfs. You cannot close them. They have multiple feeders. So you got to be very careful there. So the complications are very different. So this is one, this happened, this is what I was thinking, well, maybe I shouldn't have done it. So then you look at the indication again, very crucial. This is a Euro CTO club score. I'm not going to go in all the details, but let me show you one thing, and that's this thing. Somebody put retrograde CTO PCI masters, and the procedure was for 6 hours. Guess what? You're not doing any good to the patient. You're just exposing him as a guinea pig. You're exposing him to a ton of contrast. You're exposing him to a ton of radiation, and that is unjustified. So volume is very crucial. If you look at the success rate, a lot of folks say, oh, my success rate is 90%. Well, you may be saying the truth. Here's, if you are doing JCTO 01, integrates very successful. But look at the JCTO 4 and 5. The success rate antegrade is no more than 15%. Well, how do you go up on that? The only way to go up on that is you add retrograde to it. And if you add retrograde, you can go up on that, but this is at a price. Well, what is the price? We are doing, most of us do the conventional reverse cart, and it does have complications. So the perforation rate is about 11%. I was just reviewing my Michigan State University data there. It's not showing there for some reason, but the MACE is 13%. And it all depends on the operator experience. If the operator is inexperienced and he just started, guess what? He is in trouble. He has a much higher complications then. I think my time is this thing. Yeah. So added cost, to cut down on it, I came up with this proximal capillary diswas, and I'll explain it to you. This is what I explained in 2020 in our cardiology meeting over there. What you do is I came through the epicardial diagonal, came back. This pointer is not working for some reason, but anyway, what happened is once you come across to the proximal cap, you check the pressure. if your pressure is fine, obviously IVUS cost, IVUS is ideal, as Dr. Sail Aziz said, but the cost adds there. So then what you do is you make it renderized procedure by putting another wire and getting antegrade and make it an antegrade procedure. This will explain it well. The proximal cap is okay. So you come through once you come across and you do all the reverse cart, then you get a new wire and you enter antegrade and you switch it from a retrograde to an antegrade procedure, cutting down on the cost. I'll just quickly show, because the time constraint. This is a patient RCA long lesion. You can see by including bifurcation. The main dilemma here was that this PLB and PDA are all kind of straight line. The distal RCA is way down in the straighter portion. So what I did was, when I came through this stent, this guy had a LED stent there. I came down there, crossed it with a wire. The wire would always go in PLB, and that made it very difficult. So with time you become more bold, you become more careless. So I got a Suzuki, and when I made the curve over there, Suzuki was stuck. And when I pulled it back, it was in bad shape. So you get more gutsy, but you are exposing these patients to a high risk rate. This is when you externalize the wire, and this is the tip-in procedure shown on the right. Again, but this costs more because you are getting another microcatheter there. You switch it to an antegrade procedure, distal angioplasty is done, and one stent, long stent is placed, and then another long stent is placed, and you have a good result. The point, so you can see that the bifurcation is saved. It's very crucial. If you have done it antegrade and you mess up the bifurcation and you saved one artery, no good. You're not doing any good to the patient. My point is that if somebody wants to have it, they should have all the gadgetry. They should have patients who can afford it, and they should get proper training, not see one, do one sort of a one meeting you go to or you get trained for a week or 2 weeks. No, that's retrograde is not one that should be done that way. Thank you very much.